helped many practitioners across India in refining their skills. Today's session will focus on the essential techniques and insightful tips designed to enhance predictability and quality of composite restorations in daily practice. With that, let us extend a warm welcome to Dr. Shaili Mehta. Over to you, ma'am.
Ma'am, your mic is off.
Sorry. Yeah. Thank you so much for the opportunity. Again, I think this is our second webinar with this cohort, and it's always been a pleasure talking to you guys. Amazing team and amazing organization. Now, without wasting much time, let's just dive it into the topic. So, I'm sharing my screen. Is my screen visible?
Yes, ma'am.
So, yeah. Okay, so a little bit about me. I'm Dr. Shaili Mehta. I graduated from a college called MGM Dental College, that's in Navi Mumbai. Then I went ahead, gave my NEET exam, scored All India rank of 44, and did my MDS in my dream branch from my dream college, that is Government Dental College and Hospital. Then I was assistant professor at GDC Mumbai for a year, and now I'm a private practitioner in Navi Mumbai and a proprietor of Dental Dream Academy, which basically conducts courses all over the country for upgrading dentistry. So that's a little bit about me. Now, a little disclaimer, this is only for information and educational purposes, and it is not sponsored by any company or organization and does not have any monetary benefits. Now, when I say one simple thing, composite restoration, what is the first thing that comes to your mind? Now, I believe here I'm talking to a crowd that's already been practicing dentistry for at least 5 years. So, at least I'm talking to interns, or maybe you're in final year or a practitioner. Now, looking at all these scenarios, when I say composite restoration, these are the things that comes to your mind first. It's a broken margin, there is discoloration. Now, this could be a regular OPD that you are doing in your area or your college, or it could be a composite restoration that you have probably done 3-4 years back, and the patient has just come for a follow-up, and this is what you see. It is pretty heartbreaking. And I'm sure if you are an endodontist, or are in contact with any endodontist, senior endodontist, the first thing they say is amalgam is better than composite. Now, why is that? You see something like this, you have fracture, gaps, leakage, micro leakage, everything, sensitivity. Why? So, why do people say amalgam is better than composite? Now, amalgam is something we've been taught and learned in our 4 years of BDS. Every day, literally, you were going to college to only learn amalgam. In your exams, you had amalgam. Every day, you were completing your quota about amalgam. So, amalgam, as such, has become a part of your muscle memory now. You can't go with wrong with amalgam. Every day you show any cavity, irrespective of you're in second year, third year, final year. Every time you go to your instructor, they would ask one random question about amalgam. What is the KO surface margin? What is the thickness of the base? What should be thickness of amalgam? So we are so used to working with amalgam that now when you do composite that you've just started learning in your internship, or probably after internship, you're confused. 4 years of BDS, you've only done amalgam, and the moment you come out of college, यार ये तो करना ही नहीं है. What you have to do is actually composites. So if you're not good at composite or something like this happens, do not worry. You are new at learning composites. You have not been taught properly how to do composites, and now suddenly I give you a new material. So the first thing before beginning the webinar, I would like to say is all this comes after 4 to 5 years of hardcore clinical practice. It's not an overnight thing. So if you want to move from something like this to a peaceful, mindful dentistry, which looks something like this, it takes time and it takes efforts. So, with this, I would like to start our webinar, which is basically on tips and tricks of composite. Now, over the past few years, I've realized some common challenges that we all face in posterior composites. Now, the first one is obviously post-operative sensitivity. The second is our micro leakage, and the third is secondary decay. Now, the reason all these three happen is only one, which we have been taught in our BDS days, and we've written literally answers or LAQs on it, which is just a simple thing: polymerization shrinkage. Apart from that, proper contour and contact, which is even a problem in amalgam. And another additional problem that we have now is shade matching with composites. Now, it's not very important for a posterior, because we are talking about posterior composites today. It's not very important to have an exact shade match, but unfortunately, because of this attitude, we are using any and every shade in posterior composites. Now, the shade as such, there has no difference in the properties on a larger scale. But if you are charging patient a lot, and for your own understanding, after you do your composite, you should feel happy about it. That is where shade matching is very important. Okay, so first is post-operative sensitivity, marginal discoloration, and secondary decay. All three are related to this one common problem, which is basically polymerization shrinkage. Now, as I said, we have all read about it, learned about it, but now today let's have a deeper thought on what exactly polymerization shrinkage means. So, with this, we begin with our topic. Now, the logic behind this webinar is going to give you an outline on basically how you're supposed to do composite restorations in a peaceful, mindful way. So, for doing that, we need one simple protocol, because you've been taught about protocols in amalgam and you're so good at it. Your amalgam carving is good. I've rarely seen anyone having troubles with amalgam by the time they're in internship. The problem only happens with composites. So let's have a protocol today, which is basically divided into preoperative, intraoperative, and postoperative protocols. Now, when I say the first thing, preoperative procedures, or the things that you need to do before the patient comes to your chair. Now, we all know that composite is a technique sensitive material, it needs isolation. So, when we are doing composite, this is what we do. We put n number of cotton rolls, we put saliva ejectors, high wax suctions, everything we do that. But the moment you look away from the patient, this is what the patient does to you. Now, a simple solution to this is rubber dam isolation. Now, rubber dam isolation could be a single tooth isolation, it could be a multiple tooth isolation, or it could be something as complex as this. Now, here it is not my saliva that's a concern, but here it's a upper maxillary, it's a maxillary tooth. So, saliva flow I can still control with cotton rolls or suction and everything. But here my main problem is the leakage from the GCF, that is the gingival clavicular fluid that comes from the gingival sulcus, and along with that, since the cavity is very equigingival or subgingival, there is going to be also blood coming out of this sulcus. Now imagine if there was no rubber dam isolation in this case, I would have completely leaky margins either with GCF or with blood, which I don't want. So when you have cases like this, it literally becomes impossible for you to actually go ahead and do a quality work if you don't have rubber dam isolation. Second thing I've seen is whenever we are doing our composites in college, we usually have a workstation from where your sister or your helper is gonna give you all the material, your etchant bonding, and then sometimes what happens when you're working, you forgot etchant or maybe you forgot your bonding agent. Or the worst, when you're working in colleges, you usually have one or two curing lights among 10-15 people. So you're doing composites, you think you have your curing light, but by the time you start curing your composite, your friend has already taken the curing light and went away. This is a very reliable situation that happens. It used to happen with me in my college when I was an intern. When I was an intern in charge, when I was teaching my students, this is something that happened. Now, for composite, just as you have for amalgam, make a checklist. Make a checklist of things that you need for composite. Make a checklist for that you need for class 1 composite, class 2 composite. Now, whenever you're doing class 1 composite, always have your class 2 materials ready as well, because unless you have taken a radiograph and you're very sure, most of the times your class 1, if it's a little deep, gets converted to class 2. So do not be in a hurry, make a proper checklist and then go ahead. Now we talk about our pre-operative protocol. The third thing that we need to know is basically have a good check on the occlusion. Now, this is a serious recommendation. Whenever the patient comes and you're starting your work, take a articulating paper and check the bite. Ask the patient to bite and see how many points he has of contact. This will help you in two things. First, you will avoid having any form of high points. Second, you will also realize the biting force and the biting pattern of the patient. Now, this is very important because you must have realized after you do composite restorations, even if you've done a beautiful contouring of the cusp and the ridges, the moment you check your high points, it's all flat. You take your burr and you may literally make it flat. So, to avoid that, take a articulating paper and check the occlusion freehand. Next is check the contact and contour. This is irrespective of the material, even if you do it in amalgam, if you do it in composites, it's going to be the same. The struggles that you have in amalgam are going to be a little more multiplied when you do composites, when you're building up a contact, because composite is a plastic material. So, but nonetheless, if you know exactly if your matrix band adaptation and selection is good, then your contour and contact is going to be much easier than amalgam, because in amalgam you have very limited options to build contour and contact, but in composites you have a wide range of material. So these are the pre-operative protocol. The last thing is curing light. Now this is something that we usually ignore, but it's the most important aspect. So the curing light intensity given in textbooks, that is the minimum we have to use, is 400 milliwatt per centimeter square. Now most of the lights that you've seen in market, or the curing light that are available in market, this is what they sell. They recommend or they have curing lights above 1000. Now why is that? Whenever you buy a curing light, irrespective of how good it is, over time it decreases in its intensity. So even if you have 1000 watt per centimeter square, it's not going to be the same after 6 months or 8 months or 2 years. The intensity decreases. So that's why it's always recommended to have a very good curing light. Now, this very good curing light would be from a standard company. It could be either your Ivoclar, Dentsply, or 3M. 3M Elipar is considered to be the best right now. So these curing lights will help you to achieve a uniform intensity while curing. Apart from that, whenever you buy a composite, you say bulk fill or you say your SDR, which the company claims that you can cure it up to 4 mm. Now this 4 mm is with a good curing light. If your curing light is not good, then this composite material is not gonna be acting to its full potential. So curing light again is a very important part of your pre-operative protocol. Now moving on to intra-operative procedure. First is caries excavation. Now in amalgam, we've been taught this simple thing. We see a caries after rubber dam isolation, we take our burr and start right from the center of the tooth. Okay, most of us do this. Now tell me one thing, in composite, I'm sorry, I've spoken so much about amalgam that I might get confused now. So whenever I'm talking about composites, we need a strong margin at the enamel. We all know enamel bonds better to composite rather than our dentine. So if we start with our conventional caries excavation pattern, where we start from the center and move towards the periphery, we are not achieving a healthy enamel. So this is our conventional way of caries excavation. But rather than this, just make a little change. Start your caries excavation from the sides. Once you do that, you have a healthy enamel at the sides and the decay is left in the center. This is basically called as a centripetal caries excavation pattern. After this step, you apply your caries detection dye. Now, this caries detection dye is going to help you to evaluate your affected dentine and your infected dentine. So, once you're done with application of your caries detection dye, these are the three zones you see. You have your superficial enamel, you have your affected dentine, and then you have your infected dentine, which is basically a central stop zone, caries removal endpoint, and peripheral seal zone. Now, once your caries excavation is done, your cavity usually is in dentine. We go ahead and apply our etchant, wash it, then apply our bonding agent, and then cure it. Then we apply one layer of composite in a very thick manner, and then again we cure it. Now let's understand what exactly happens. You've applied your composite and you cure it. Now I'll talk about something called as the hybrid layer. Something that we've all learned in our BDS. We've written definitions, we are given vivas. But now, does anyone remember what hybrid layer is? Whenever you etch your enamel, we all know that it creates micropores in the enamel and dentine. And then you apply your bonding agent, your bonding agent goes and seeps into these pores. The bonding agent that goes and seeps into these pores is basically what forms your hybrid layer. So here in this picture, the red area, the red line depicts your hybrid layer. So the layer basically after you have etched enamel which has pores, and in those pores your dentine bonding agent goes and binds. Once you cure it, that is your hybrid layer. Now, why is this hybrid layer important? Whenever you cure composites, earlier you it was taught to you and it was also given in textbook that the composite shrinks towards the source of light. Later on, studies show that it is not so. It shrinks towards the center of mass. Now, when it shrinks towards the center of mass, the forces are so tremendous that it takes away or breaks your hybrid layer. If you apply your second layer of composite and again cure it, it leads to even further shrinkage. Now, as a rule, body does not like any cavities. Whenever you have cavity, blood is your body is going to either fill it with blood, abscess, or something like that. Now, why is that? Now, here in dentine, the only fluid we have is our dentinal fluid. So, body is trying to fill up this cavity with dentinal fluid. And by the definition of hypersensitivity, we know that dentinal fluid movement, rapid movement of dentinal fluid to and fro causes hypersensitivity. So this is the time when after your composite restoration, patient calls you after 24 hours to 48 hours, doc, I have sensitivity. This is the reason why. This dentinal fluid creates tremendous pressure again, and by law body again does not like any discomfort. So body is going to try and get rid of this dentinal fluid through our fluid exchange channel. So whenever your patient calls that, doctor, I have sensitivity, what is your reply? Wait for 15-20 days, it will go. Now how does the sensitivity go is by this. The pressure is released, so the pain is gone, but now the bigger problem is there is exchange of fluid between your dentinal fluids and your saliva. So because of this, the pain of course goes, but you are inviting a bigger problem, which is your exchange of bacteria between your saliva and your dentinal fluid, which ultimately leads to secondary decay. Now, this was one of my students who came. Now his chief complaint was pain and sensitivity in the tooth. He suspected it to be from the distal cavity. He said that the mesial cavity was restored 2 years back with a typical symptom. We had sensitivity for 15 days, after which it's vanished, and it's been asymptomatic since then. That's what he thought. We went ahead with rubber dam isolation. The moment isolated the tooth, I realized there is something fishy beneath the composite. So we removed the composite and see how much decay was there beneath the composite. Now, this is exactly because of secondary decay. So, your primary decay is going to be a little less aggressive that you can see on the distal side, but your secondary decay is going to be highly aggressive. And this is what has happened. So, the mesial cavity was a bigger culprit than the distal cavity here. Now, why does all these things happen? It's because of a simple concept called as hierarchy of bondability, which we have all studied. So, we all know that as we go down from the enamel, the bonding strength decreases. So enamel is the strongest bond, superficial dentin is less helpful, deep dentin is even less, and the last is radicular dentin bonding is even lesser. Now this is the problem. Now why does this happen? We've all been taught about difference between enamel and dentin bonding. All of us know this. Now, when I say enamel and dentine bonding, let's have a real life example so that you can never forget this. Enamel is basically like your Feviquick and dentine is your Fevicol. Whenever you've tried to stick anything with Feviquick, you take the material, you basically apply it, and you just take it together and it sticks. When we talk about dentine, you take, as you're seeing your carpenters work, they take a piece of plywood, they apply a Fevicol on it, and they stick it to the surface they want to stick. This is basically that the time that you give your Fevicol to mature is the same time you need to give your dentine to mature. So how do we make this happen? Is by immediate dentine sealing and decoupling with time. Now, as I said, whenever you take your burr and drill in a cavity, you are always leading to some damage to your dentinal tubules, which leads to outward flow of your dentinal fluids. Once the flow has started, we need something to stop this flow and seal the dentine properly before we can apply the next layers. That is what is immediate dentine sealing, and it was suggested by Pascal Magne to apply a layer of bonding agent. Now, this bonding agent, what they recommended was OptiBond FL by Kerr. Why was this recommended? Because it has a filler content of around 70%. Because of such high filler content, whenever you apply this bonding agent, it automatically creates a very thick layer on dentine. Now, unfortunately, this bonding agent is not available in India. So, what Pascal Magne has recommended is that use a universal bonding agent. Now, why a universal bonding agent? Because a universal bonding agent has some amount of etchant or a weak etchant within its composition. So, you are done preparing your cavity with a burr, you directly use a universal bonding agent, you apply it to your walls in very thin quantity, sorry. So you apply it as thin as possible. Now, since this bonding agent does not have a good filler content, after you apply your bonding agent, you scrub it for 20 seconds, you cure it, and you apply a very thin layer of flowable composite. Now, obviously, we know that flowable composite has good amount of fillers, but always remember flowable composite is going to be weak. Here we are not doing this to provide strength. Here we are doing it to prevent sensitivity, to have our dentine sealed. So we have our bonding agent. You apply your bonding agent, you sub it for 20 seconds, you cure it. Then you apply your flowable composite in a very thin layer and then cure it. So that is your immediate dentine sealing. Now, what is decoupling with time? It's exactly the time you give the Fevicol to mature. So after you are done with this step, you applied your flowable composite. Now wait. Studies say that minimum 5 to 30 minutes is something you are supposed to wait. Now, why are we waiting? It's for the hybrid layer to mature. Now, if you've realized in this entire process, if I ask you all to wait from 5 to 30 minutes, it is absolutely impossible to do so without rubber dam isolation. So that's why we have divided into pre-operative protocol. So you considering that you have your rubber dam in place, you've followed all the procedures, you've applied your universal bonding agent, you've applied your flowable composite, you've cured it now, and now you wait for it to mature. So studies say that even if you wait for 2 to 3 minutes, you can expect an increase in the bond strength by around 30% because the hybrid layer is now mature. Ideally, you're supposed to wait at least 5 minutes. So that's our decoupling with time. Once you are done with this, you can, if your cavity is very deep, you can go ahead with something called as fiber reinforced composites, wherein you take a fiber and you place it over composite. Now, this again, if you relate it to real life example, it's something to having your iron rods within concrete. Concrete as such is very strong, but with the help of iron reinforcement, it becomes even stronger. Similarly, composite itself is very strong, the newer composite. But with the help of these fibers, you are just reinforcing the cavity. So a common the fiber that is available is a rebond fiber that we can use with composites. So after applying fibers, we cure it. Now, after you apply your fiber, the how to apply your fiber, you have to take your fiber, dip it in a little bit of your bonding agent, put it in a cavity and cure it. Then again apply a very thin layer of flowable composite. Now this flowable composite is just serving the purpose of preventing any voids in the composite, because if I have fibers and I directly use packable composite, there's going to be a lot of voids. So if you have these voids, it's obviously going to make the cavity weaker. So with the help of flowable composites, I make sure that I don't create any voids. And the last thing is our post-operative protocol. Now, something that we've not been taught exactly in our dental schools is oxygen inhibition layer. Now, what does this mean? We all know that one layer of amalgam bonds to another layer of amalgam with the help of excess mercury. Now, ever wondered how does one layer of composite bond to another layer of composite? It's through something called as a free radical. So you have your composite, and on surface of composite you have free radicals which are highly reactive, and when you place your second layer, your free radicals bonds to the second layer and creates a very strong bonding. This continues till you have reached the top layer. Now, once you've reached the top layer, the layer on the top still has your free radicals, and now it is highly reactive. So it's going to react to all your stains, your turmeric, your chili stains, then your tea, coffee, then you have dust particles. Everything is getting to go get stuck here. This is the reason that you do your composites, and after 3 4 days, the patient comes with a completely yellow restoration. So this, to prevent this, we need a simple solution. We need something that is water soluble and which will not affect the composite property. So the simple solution is to apply one layer of either KY jelly or glycerine, which you can easily get from any medical store. So the name is KY jelly or glycerine. So you apply it on the surface and then you cure it. Once you do that, you have made all the active radicals inactive because they have already bonded to your glycerine or KY jelly. So this is how you prevent your oxygen inhibition layer. Now, when we are talking about posterior matrix band and retainer, there are a lot available in the market. If you ask me, this is a common question that comes in the chat box after the session by in all lectures, which is that one matrix system I recommend. You cannot have one matrix system. Every tooth is different, so you need to have your armamentarium right. So till date, there has not been a single case where I can say in the same patient also, if it's a 1/6 and 2/6, I might not be able to use the same matrix, but in the same patient, because it all depends on how much tooth structure you have left, how much contact and contour have to build, what is the exact occlusal anatomy of the tooth, and etc. But if you want to just have a simple idea, these are the two types of matrix band and retainer that you definitely need. The first one is the TOEFL man. Now I've seen this amongst PGs. The moment they are done with their endocons PG exam, the final MDS exam, they throw away this band without realizing that how important, when you have to build a tooth circumferentially, this is the only matrix band that's going to help you. Now, when we talk about our sectional matrix band, lot of sectional matrix band are available. The only criteria that I personally look for is the gap that you have for the wedge. If you can see here in the end, you have a V-shaped structure. That's for the wedge to pass through. So whenever you have any form of, you're buying any form of matrix band, or sorry, a retainer for your sectional matrix, always buy something that provides an assembly with a wedge. So if you can see here, the TDV, the rings that are in the bottom corner, that is the pink ring and the aqua ring. Here it is basically like a stopper. If you're using this kind of matrix system, then there is no space for your wedge. Now, since you have no space for the wedge, your contact is never going to be proper. When I say we need a proper contact, this is what I mean. So your wedge has to be perfectly adapted, your matrix band has to be perfectly adapted, and then you go ahead with your composite buildup or your amalgam buildup. If you have something, a clinical scenario like this, where your matrix band is loose and this blue thing could be either your saliva or your rubber dam. If your matrix band is not well adapted to your cavity, you will see the color of your rubber dam underneath, in the space between your matrix band and the gingival seat. So your gingival seat and matrix band should be very tight in contact. You can take a probe and check it. And again, to support this, you need a proper wedge. In this, the first scenario, the wedge is also somewhere else. Now you can have a scenario like this where you've compressed the wedge too much, so it is very tight in the gingival area, but look at what has happened near the marginal ridge. It's creating a very over contoured restoration. So we don't want both of these situations. So whenever you are adapting your matrix band, make sure the adaptation is correct. Now, whenever I talk about class 2 restorations, the only way of clinically identify whether you've done a good job or not is to take a radiograph. Always take a radiograph, preferably a bite wing after your class 2. Now, the problem is in our BDS days, we've been only taught to take preoperative radiograph. Why? To get the case approved from our instructor for exams, your midterm, prelims, your final exams. So you just take a IOPA to just, you don't even care, you don't even look at the IOPA. You literally go and run to your instructor ki yaar approve kara lo. Bas. Now you're not giving any exams, now you're in clinical practice. So now the IOPA evaluation is for you, not for your instructors. So go ahead, take a preoperative IOP and take a postoperative IOP after your class 2 restorations, irrespective of if you are still in college, take it after amalgam also. You'll be shocked to see how much overhang or how much problems are there in your restoration. If you're doing composites, first of all, the biggest problem you'll have is voids. Till now in clinical practice, I, after doing a class 2, I always take a radiograph and I have this little bit of anxiety and butterflies in my stomach that what if there's a void. This is a common thought that I always have. Now when I talk about in the last almost 1 hour, what we have spoken was stress free dentistry. Now how do we achieve it? If you all want, you can take a screenshot of this if you are allowed to. So we have pre-operative protocols, post-operative protocols, and your intraoperative protocols. When I talk about pre-operative, Rubber dam, checklist, check occlusion, check contour, and have a good curing light. Intraoperative includes your caries excavation, immediate dentin sealing, decoupling with time, bratrix band, and retainer selection. Post-operative is your oxygen inhibition layer and finishing and polishing. Now, finishing and polishing is something that I would like to discuss with our clinical cases. So, we are done with the theory part. Now, let's move on to the clinical cases because, of course, I'm a full time practitioner, so I can't have a lot of theory. So, moving on to our first case, which we've discussed already, centripetal caries excavation. We apply our caries detection dye, and this is what you get. Then we apply. Now here you can see this little shiny surface. This is what I have done. I've applied a layer of my universal bonding agent. I've cured it. After that, I apply a very thin layer of flowable composite. Now you can see how thin the layer is. Then you again cure it. Now I see there's a deep cavity. It's not very deep, but it's wide. So what I do is I do something called as fiber wallpapering. So I've applied my fibers on both the side to strengthen the tooth structure, and then I cure it. Again, I apply a layer of flowable composite. Then I go ahead with my selective etch. Here I'm only etching enamel. Till this point, I have not used my etchant. But if you ask me the common questions that people usually ask, first thing they ask is whether you are supposed to use etchant on dentine. The simple answer is wherever you can use etchant is going to increase the bond strength. But if you have a very deep dentine, if you use your etchant, you are going to cause sensitivity. So if you have a thought, if it's a shallow cavity, if you have a thought whether you should use your etchant or not, definitely you're supposed to use your etchant. Any and every condition where you can use etchant, use etchant. Second, people ask is, the steps. So this is a revision again. So I remove my caries, I apply my universal bonding agent, I scrub it, I cure it. Then I applied my flowable composite, I cured it. Then I'm etching it. After I etch, again I use my bonding agent, cure it, and then start with my composite buildup. So it's an incremental buildup, and this is what we usually expect in clinics. Now, if I send the patient back like this, patient is definitely going to come back with a yellow restoration, and we don't want that. So what is going to happen is we have to finish and polish. Now, this is a common myth everyone has: posterior composite does not need polishing. A very wrong myth, because tell me one thing, when you're doing composite restoration, you're using the same syringe, right? You're using the same composite syringe for your anterior composite and for your posterior composite. You're using the same material. So how would composite know उसको आगे के दांत में प्लेस किया है या पीछे के दांत में? If it's placed on an anterior tooth or a posterior tooth, how would composite material realize that? It can't, right? So if you have discoloration, yellowishness in your anterior, the similar thing is going to happen to your posterior teeth as well. So that's why it's important to finish and polish. And apart from thousands of materials being available in the market, here is my simple. Earlier when I used to do composites in my PG, I used to use 10,000 different things. Still, I never got a good result. Now I have a simplified version of what you need to use for finishing and polishing. You can take a note of it. First is a disc. So this could be, by the photo you are seeing here is by 3M. So you can have a 3M disc. It's a series of 4. The name is Soflex. Or you can have a disc system by Shofu, which is your Super Snap. Even that's good. So again, that's a sequence of 4 discs. So you go from coarse, medium, fine, and extra fine. Once you are done with your disc, you move on to your polishers. Now your polisher, what I like is EB Twist. That's again by Ivoclar. And then if you want to use your 3M system, you have Soflex spirals. So you have always your pre-polisher and your polisher. And now this was something I used to use in earlier days. Now I don't use it. This is something called as Buff. It's called Super Buff by Shofu. Now this is similar to how you used to polish your denture. Remember the last was the buff wheel that we used to apply for the shine. So this works in a similar manner. This is just for the shine, but I did not get any good results, so I don't use it anymore. So this is how your composite is supposed to be looking, extremely glossy. This is after checking the occlusion. Now, if you realize there, this is something that usually happens to us. You've made a beautiful composite, but after occlusion reduction, this is what happens. So to avoid that, you also need to check the pre-operative occlusion. Now here is a case, again a student of mine. Here what has happened is his amalgam is fractured. This kid is 22-year-old. Now my concern here is not only the fracture of amalgam, my concern is also here that the kid has a facet. There was no amalgam in the mesial cavity. It was just a pure facet. And look at 7 here. 7 is intact. So that means there's something wrong with the occlusion of only 6. Later, after checking with the articulating paper, we realize there's a plunging cusp from the lower side that's disturbing this amalgam and the restoration. So in such cases, you cannot have a great anatomy. You can't have very sharp ridges, cusp and everything. You need to give a subtle anatomy. Because I want the restoration to survive. I don't want it to just look good on Instagram. I want the restoration to survive. So there's absolutely no problem with the amalgam here. The only reason it's fractured was maybe the occlusal forces were not taken into consideration. So we go ahead with our rubber dam isolation and see how subtle the anatomy is. No fancy anatomy, no extreme cusp, just a simple anatomy. This is a simple class 2. This is a case that we've seen. Now earlier I used to do a lot of staining. I don't do that anymore because again it's not helping the patient to have a long term good results. It's just for me to post on Facebook and Instagram, which actually we don't need anymore. Apart from that, whenever you do staining, if the patient decides to go to another dentist, they might mistaken it for caries and dig it up and make a class 1 again. So we don't want that. Again, if you want to make your life simple, this is again one of my cases. So I always say, we need to have a peaceful mindful dentistry. So to do that, whenever you have class 2, the first primary objective you should have is to convert your class 2 into class 1, so it's very easy for you to work. So always, whenever you have a class 2, convert it into class 1 and then go ahead. So this is the IOPA. You can see there no overhang. The restoration is proper. Always take a IOPA after your class 2. Again, a class 2 restoration done for another dentist. Now this is a very interesting case which, if you have any doubts between selective edge and complete edge, this is going to solve it. So here we have 4 teeth, out of which 6 is a little deep. Rest of the teeth are almost in the superficial dentine. So here what I did was I went ahead with isolation, caries excavation. I applied my universal bonding agent only on 6. I cured it. I applied a flowable layer of composite. I cured it. Then I took my etching, did selective etching on 6, and for the rest of the teeth I did total etching. Once this was done, I rinsed it off. I applied my bonding agent, went ahead with composite. Again, I've used staining here. Now I don't use that or either recommend it, but still, if you want to learn it, this is the shade that I used. It's by Tokoyama. This is the stain that I've used in this case. Again, our composite build-up. So now we've addressed all the challenges. The first is our post-operative sensitivity. The second is marginal discoloration. Third is secondary decay, which is all overcome by a simple policy of avoiding polymerization shrinkage. We saw how to select our matrix band and retainer. And the last thing is shade matching. Now, when I say shade matching in composite dentistry, when you have your anterior shade matching, there are 1,000 techniques in which you can have your shade matching. But when I say posterior composite, do not need to have such an extensive protocol for shade matching. You can just use your simple button technique. You can use your dentine shade Now, why dentine shade? For that, you need to attend my workshops for why dentine shade. And if I say that in interiors don't use button technique, so why that? Again, you need to attend my workshop to understand why button technique should not be used in interior composites. So we are done with this. When I now I would like to conclude by saying this one simple thing: whatever you saw in the presentation is after a hard work of around 3 to 5 years. It is not an overnight thing. So if you are good at amalgam and you want to improve in composite dentistry, you need to give yourself time. You need to practice it every day. If you want, most of the times my composite practicing is on extracted teeth or typhodont. So it's not necessary that you need exactly patience to do this. You can also do it on extracted teeth. At least you're carving, understanding the anatomy, taking pictures of pre-op, or you can wound two teeth together like we did it in our preclinical exercises for amalgam. You can build up your class 2 composites as well. So all this is over the years it has come. It's by practice. So if you are still learning composite dentistry, it's going to take time, but I'm sure in a much faster rate than I took because there was no one to teach us. It was all through, articles and videos and stuff like that. But now there are so many mentors that are ready to help you. So your learning curve is going to be much faster. So with this, I would like to thank all of you all for your patient listening, especially at 9 a.m. on a Sunday morning. Thank you so much for attending the session. If any one of you all have questions, we can begin with the session, and you all can connect to me on Instagram or write out to me email as well. So we are open to questions. A big thank you for Five Star for all this for organizing this and giving me this opportunity again.
Ma'am, we have some questions. First one is from Nikki Agarwal. How to avoid marginal discoloration?
Yeah, hi. I think that was answered in the session. So the entire present marginal discoloration happens because of polymerization shrinkage. If you prevent your polymerization shrinkage, you avoid your problems. I think you must have joined late or something, but you can provide a recording, right? Yeah. So please do check out. It's just basically you have to prevent your micro leakage. To prevent your micro leakage, obviously you have to contain your polymerization shrinkage.
Next question is, can you kindly share the sequence of finishing and polishing of composite again?
So you have simple system, you have your disc and your polisher. So you have your disc and your spirals always, irrespective of the company. The company that I use is by either I use one system that is 3M. So 3M I use disc and spirals, or if I want to shift companies, I use disc by Shofu and I use the spirals by Ivoclear.
Next question is, how to check occlusion via articulating paper?
So once the patient is on the chair, you have to take either you have articulating paper holder tweezers, but if you don't have that, you can use a normal tweezer. Take your articulating paper. The recommended company is by Bosch. So that's a ideal company you're supposed to use, not your this carbon copy they use. Don't use that. So what you need to do is you need to hold it and ask the patient to bite on the side you're working. And once you're done with that, check for the marks, check where the tooth is actually articulating. Either it's in the marginal ridge, or how much part of the cavity that the caries is involved in the occlusion. So once you remove that, you have to rebuild it. If it's a very small class 2, you only need to have the contact in the marginal ridge. If it's a class 1, very small class 1, which is not in occlusion, so you don't have to worry about that.
Uh, Next question is protocol while applying pulp protecting agents, how to do inversion of rubber dam.
Pulp protective agents are something that is not recommended right now. If you have, the only reason I would do that is when you have a direct pulp capping, that too in a case where, it's a young patient, I don't want to go for a root canal and stuff like that. Apart from that, in whatever we spoke today, where there is no pulp exposure, I do not apply pulp capping agents. Inversion of rubber dam is, I usually do it with an instrument. That's the easiest way. You have a sharp instrument where you tuck it inside your gingival seat, and then it automatically gets inverted. Or if you can also use a floss tie for inversion of rubber dam.
Next question is how to avoid gaps in composites in radiograph, how to restore occlusal wear facets.
So occlusal wear facets, first of all, check how the pattern is. If it's a generalized pattern, then after restoring, immediately give a night guard or something to protect it. The point is not just to restore it, but is to protect your restoration as well. Apart from that, what is the first thing? Like occlusal wear facet one?
It was how to avoid gaps in composite in radiographs.
So it's not, if your gap is there in the restoration, that's why it's on the radiograph. So avoid the gaps in the radiograph, in the composite as well, in the restoration. Basically, what you need to do is use very small increments. The way you condense your amalgam, you're supposed to actually pack your composite. You're not supposed to apply one layer, cure it, apply second layer. If you do that, you're going to have voids. So apply very thin layer, but apply it and pack it properly, and then apply the next layer.
Okay. Next question is after decoupling with time, etch in ml, then wash, then all composite done till this time, don't contaminate it.
Yes, so you apply your bonding agent, universal bonding agent, rub it, scrub it properly, cure it, apply flowable, cure it, wait. Now, after you're done with 5 minutes, apply your selective etching, then wash it, apply your bonding agent, and then go ahead with composite. Once you've waited for 5 minutes, between etching and your flowable composite, there should be a gap of 5 minutes. Apart from that, then you don't need to wait. Then you can immediately move, only provided you're using very small layer of composite. So even if it shrinks, basically I'm trying to minimize the C factor. So even if it shrinks, the shrinkage is minimum.
Which rubber dam sheet is best?
So I usually use a sheet by MCare. So MCare, Sanctuary, both are the companies that are good. I personally like these two sheets. Even Colteen sheets are good.
Okay. How effective is camo mechanical caries removal? Any recommended brand?
No, it's still in studies, but not recommended as of now.
How effective is the jelly applied on the composite to act as oxygen inhibition layer? Any recommended brand?
So KY jelly is one recommended. It's not a brand actually. It's like glycerine, whatever glycerine you can get it from your medical store. And a better way is to get KY jelly. KY jelly you get it as KY jelly only. It's a blue color pack.
What are your thoughts on preconditioning of dentine?
So preconditioning of dentine was initially proposed. Basically, it's an additional step where you use your matrix metalloprotein inhibitors. Something like you apply your chlorhexidine or you apply your alcohol on top of dentine for your preconditioning. But now they have, with studies, they have reported that it's not very important. All the systematic reviews have concluded that it is not very important. The bond strength is not that great. You can achieve the same amount of bond strength with this protocol which I just said, and obviously we are all lazy, so we don't want to increase the steps in composite dentistry. Whatever we have, we're happy with that.
At composite and teeth structure, some minor black line are seen after composite buildup in radiograph. Is it okay or bad?
No, it's very bad. So that is basically your dentine bonding agent is very thick, and you have a gap between your composite and your dentine. So if you saw the radiograph that I've shown here, there absolutely supposed to be no gap between your dentine and your tooth. You're not supposed to, able to distinguish between the two.
My rubber dam comes between matrix and tooth. How to deal with this situation?
So whenever you have something like that, what you can do is you can stretch your rubber dam, apply basically your matrix selection is wrong. So to select a proper matrix system and then tightly push in your wedge. So with the help of that, you have to obviously pull your matrix. So it's not a single-handed dentistry. You need at least four-handed dentistry in this case. So you have to pull your rubber dam, apply a matrix band, and then put your wedge in.
How to remove overhanging margins in class 2?
You have to repeat it. You can't remove your overhanging. You have to repeat the entire restoration again. Select a good matrix band retainer, and whenever you're doing so, as I said, the rubber dam. If your rubber dam is getting stuck in between, one primary reason could be your rubber dam punching. When you're punching your rubber dam holes, it's not proper. So if you're not punching your holes proper, if it's very close to each other, you have wrinkles in between two teeth. That's why it's coming in between. So your hole punching in rubber dam is again important.
Can Vaseline or petroleum jelly be used instead of KY jelly?
No, so Vaseline, what happens is when you use Vaseline is basically oil based. So after you are done removing the oxygen inhibition layer, you don't want the solution to be there. So if it's oil based, it's going to be there. It's going to take some time. But when you have your glycerine or KY jelly, it is water soluble. So it gets soluble with the help of your saliva. So that's why KY jelly and only glycerine are recommended, not other things.
How to thin down bonding agents?
So you have two options. Either what I do is that I use my one applicator tip for application. I scrub it for 20 seconds. I use a fresh applicator tip and again scrub it so that the excess is gone. Second way of doing is all of you all must have done it using the three way. Now the problem with three way is you're not 100% sure whether there is water contamination or not. So usually nowadays there are two three ways given. One is on your side, one is on the assistant side. So if you have a chair that functions like that, what you can do is you can switch off the water supply of the assistant side's three way, and then you can use that, making sure that there is absolutely no contamination coming from the three way.
Next question. Okay. Do we need to give bevel on enamel of proximal box?
Yeah, I do. For enamel, for even for class twos and class one, I don't give it for class two as such on the proximal wall, but I give it for my occlusal surface. Now the reason is not that for removal or chipping of this enamel. It's only basically to have a seamless margin with the composite.
Next question is, can we use chip blower instead of three-way?
Again, the same thing. You can use anything. You can literally blow with your mouth. The only point is you don't want contamination. That's the only thing. So if you can prevent that, you can prevent contamination. You can use whatever you want.
Okay. I guess questions are over.
Okay.
Yes, ma'am.
Okay. Thank you so much for everyone for listening.
Thank you everyone for joining. Thank you, ma'am. Japlin, I guess we can end the webinar.
Okay. Thank you so much, ma'am, for giving your valuable insights on the topic composite tricks and tips. I thank all the participants for your time and engagement. We look forward to welcoming you in the future sessions as well. Until then, stay inspired and keep learning. Have a great day, everyone.
Can we end the webinar, ma'am? Okay. It's